Welcome to Pediatric Case Review. Today we will explore Angelman Syndrome, a genetic neurodevelopmental disorder. This lecture covers clinical presentation, diagnostic approach, management strategies, and complications. Designed for neurologists, geneticists, and pediatricians seeking intermediate-level medical knowledge. Let us begin our comprehensive review of this fascinating condition. Case 1. An 18-month-old boy presents with severe developmental delay. He has not spoken any words and exhibits frequent unprovoked laughter. Parents describe him as having an unusually happy demeanor with frequent hand flapping movements. Birth history was normal. What is the most characteristic feature of this presentation? The correct answer is B. Inappropriate laughter and happy demeanor represent the hallmark behavioral phenotype of Angelman syndrome. Children display an easily excitable personality with frequent unprovoked laughter, historically termed happy puppet syndrome. This distinctive behavior pattern, combined with developmental delay, should prompt genetic testing. Microcephaly typically develops after 6 months of age. Case 2. A 2-year-old girl cannot walk independently. She achieved sitting with support at 14 months. When assisted to walk, she demonstrates a wide-based gait. Parents note tremulous limb movements. Speech development is absent. What motor finding is most expected in this condition? The correct answer is B. Ataxic gait with jerky movements characterizes the motor phenotype. Truncal ataxia is a universal feature, producing puppet-like movements. Children display a wide-based gait pattern with tremulous limbs. Approximately 50% achieve independent walking by age 5 years. This ataxia distinguishes Angelman from other developmental disorders. Case 3. A 3-year-old child with Angelman syndrome develops new-onset staring episodes lasting 10 to 20 seconds. Parents observe eyelid fluttering during episodes. There is no post-episode confusion. Episodes occur 5 to 10 times daily. What seizure type is most likely occurring? The correct answer is B. Absent seizures are common in Angelman syndrome. 80 to 90% of patients develop seizures, typically before age 3 years. Multiple seizure types frequently coexist, including absence, myoclonic, and atypical absence seizures. Seizures are often treatment-resistant. Early recognition and appropriate management are essential for optimal outcomes. Case 4. A 5-year-old boy with confirmed Angelman syndrome undergoes communication assessment. Parents report no spoken words, though he understands simple commands. He uses gestures and pointing for communication and makes appropriate eye contact. What is the typical speech capability in Angelman syndrome? The correct answer is B. Minimal to no speech is typical, with most children using 0 to 5 words. Severe expressive language impairment contrasts with relatively better receptive language abilities. Most patients rely on nonverbal communication through gestures and facial expressions. Augmentative communication devices prove helpful. Notably, desire for social interaction remains preserved. Case 5. A newborn is evaluated due to family history concerns. Complete physical examination is performed, attempting to identify subtle features suggestive of Angelman syndrome. Both parents have normal phenotype. Which craniofacial finding is most suggestive of Angelman syndrome at birth? The correct answer is C. Angelman syndrome typically presents with normal appearance at birth. Characteristic facial features develop progressively with age. Microcephaly becomes apparent after 6 to 12 months. Prominent jaw and wide mouth develop by ages 2 to 3 years. Widely spaced teeth and flat occiput emerge later. Early diagnosis requires high clinical suspicion. Case 6. A 4-year-old child with developmental delay undergoes neurological examination. The examiner observes increased deep tendon reflexes and positive Babinski sign bilaterally. Muscle tone assessment is needed. What tone abnormality is expected in Angelman syndrome? The correct answer is B. Hypotonia with hyperreflexia represents an unusual but characteristic combination. Decreased muscle tone is present in infancy, while hyperreflexia develops later. Positive Babinski sign is common. This combination of upper motor neuron signs with hypotonia is distinctive. Some patients develop increasing spasticity in later childhood and adolescence. Case 7. A 3-year-old child is observed during a clinic visit. The child is constantly smiling and laughing, flaps hands when excited, and frequently keeps the mouth open with tongue protrusion. The child makes consistent eye contact throughout. Which behavior pattern is most characteristic of Angelman syndrome? The correct answer is B. Hand flapping with happy effect characterizes the behavioral phenotype. Children display a consistently happy demeanor with frequent unprovoked laughter. Hand flapping and excitable behavior occur with stimulation. Tongue protrusion is commonly observed. Unlike autism spectrum disorders, good social engagement and eye contact are maintained. This positive effect aids clinical recognition. Case 8. A family with an affected child seeks genetic counseling. Parents request explanation of the mechanism causing Angelman syndrome. The child has genetically confirmed diagnosis. Understanding the genetic mechanism is needed for recurrence risk assessment. What is the most common genetic mechanism causing Angelman syndrome? The correct answer is B. Maternal deletion of chromosome 15q11 to q13 accounts for approximately 70% of cases. Other mechanisms include paternal uniparental disomy, imprinting defects, and mutations in the UBE3A gene. Angelman is an imprinting disorder where maternal gene expression is essential for normal neurological development. This explains parent of origin effects. Case 9. During a research discussion on Angelman syndrome molecular mechanisms, the role of UBE3A gene is being explained. Understanding the protein function is important for relating genetic defect to symptom manifestation. What is the primary function of UBE3A protein? The correct answer is B. UBE3A encodes an E3 ubiquitin ligase enzyme that marks proteins for degradation. This activity is critical for normal synaptic function, particularly in neurons. The maternal allele is exclusively expressed in the brain due to genomic imprinting. Loss of maternal UBE3A activity causes the neurodevelopmental features of Angelman syndrome. Case 10. A 2-year-old child presents with developmental delay, absent speech, and characteristically happy affect. Clinical suspicion of Angelman syndrome is high. Genetic testing needs to be ordered for confirmation. What is the first-line genetic test recommended for diagnosing Angelman syndrome? The correct answer is B. DNA methylation testing is the recommended first-line test, detecting approximately 78 to 80% of cases. This test identifies deletions, uniparental disomy, and imprinting defects. If methylation testing is negative but clinical suspicion remains high, UBE3A gene sequencing should follow, identifying an additional 10% of cases. Case 11. A 3-year-old child with confirmed Angelman syndrome develops new onset seizures. An electroencephalogram is ordered for evaluation. What electroencephalogram pattern is most characteristic of Angelman syndrome? The correct answer is C. Rhythmic high-amplitude 2 to 3 Hz delta activity is highly characteristic. This pattern appears even without clinical seizures and becomes more prominent with eye closure. Notch delta waves are common. Multiple spike and wave patterns may coexist. This distinctive electroencephalogram pattern supports diagnosis and guides seizure management approaches. Case 12. An 18-month-old child with suspected Angelman syndrome undergoes brain magnetic resonance imaging as part of diagnostic workup. Parents inquire about expected findings. What is the typical brain magnetic resonance imaging finding in Angelman syndrome? The correct answer is C. Brain magnetic resonance imaging is typically normal or shows mild cerebral atrophy. Imaging is often completely normal in young children. Mild cerebellar atrophy may develop with age. Significant white matter changes are uncommon. While magnetic resonance imaging is not diagnostic, it helps exclude other structural pathology causing developmental delay. Case 13. A 4-year-old child with Angelman syndrome develops multiple seizure types. Electroencephalogram documents absence and myoclonic seizures. First-line antiepileptic medication selection is needed. What is the preferred initial antiepileptic medication for seizure management in Angelman syndrome? The correct answer is B. Valproic acid is first-line treatment for multiple seizure types in Angelman syndrome. It effectively manages myoclonic and absent seizures. Levetiracetam represents an alternative option. Importantly, avoid carbamazepine and vigabatrin as they may paradoxically worsen seizures. Combination therapy is frequently required due to treatment-resistant nature of epilepsy. Case 14. A 3-year-old child is newly diagnosed with Angelman syndrome. The family requests a comprehensive management plan. Multiple therapeutic interventions are available. Which therapy is most beneficial for developmental progress in Angelman syndrome? The correct answer is B. Physical and occupational therapy provide the most developmental benefit. Early intervention services are critical for optimal outcomes. Physical therapy improves motor function and mobility. Occupational therapy enhances daily living skills. Speech therapy incorporates augmentative communication strategies. Behavioral therapy addresses sleep disturbances. No scientific evidence supports alternative therapies like chelation or hyperbaric oxygen. Case 15. A 5-year-old child with Angelman syndrome experiences severe sleep disturbances. Parents report the child sleeps only 3 to 4 hours nightly with frequent nighttime awakening. Family exhaustion is significant. What is the first intervention to recommend for sleep management? The correct answer is C. Sleep hygiene and behavioral strategies should be attempted first. Sleep problems affect approximately 80% of patients. Establish consistent bedtime routines and optimize the sleep environment. If behavioral interventions prove insufficient, melatonin supplementation can be helpful. Avoid chronic sedative medications due to potential side effects. Addressing sleep improves quality of life for entire family. Case 16. A 12-year-old patient with Angelman Syndrome undergoes routine orthopedic screening. The patient is ambulatory but demonstrates significant ataxia. What orthopedic complication is most common in Angelman Syndrome and requires regular monitoring? The correct answer is B. Scoliosis occurs in 10 to 50% of patients with Angelman Syndrome. It typically develops during adolescence and requires regular screening. Bracing may slow progression in moderate cases. Surgical intervention is sometimes necessary for severe curves. Other orthopedic concerns include joint contractures and obesity related to reduced mobility. Annual orthopedic assessment is recommended. Case 17. A 6-year-old child with Angelman Syndrome presents with chronic constipation. Parents report no bowel movements for 5 days. The child passes hard stools and experiences abdominal discomfort. What is the primary contributing factor to constipation in Angelman Syndrome? The correct answer is B. Decreased mobility and hypotonia contribute primarily to constipation, affecting 80 to 85% of patients. Hypotonia affects intestinal motility, while reduced physical activity worsens the problem. Management includes adequate fiber intake, hydration, and laxatives when necessary. Gastroesophageal reflux disease is another common gastrointestinal complication requiring management in many patients. Case 18. Parents of a 5-year-old child with Angelman Syndrome inquire about future independence. They are concerned about adult living situations and question life expectancy. What level of independence is typical for adults with Angelman Syndrome? The correct answer is B. Supported living with lifelong assistance is typical. Life expectancy is normal or near normal, and there is no progressive neurological decline. Some skills may actually improve with age, and seizures often decrease in adulthood. With appropriate support and interventions, individuals with Angelman Syndrome can achieve good quality of life. Thank you for joining this comprehensive review of Angelman Syndrome. Key points include recognizing the characteristic happy demeanor, obtaining DNA methylation testing for diagnosis, and implementing multidisciplinary management. Please subscribe to Pediatric Case Review for more informative presentations. Comment below with any questions. Stay tuned for upcoming lectures on other pediatric conditions.